Why long-term monitoring? If you do long-term monitoring for 24 hours, you get a lot of pages of EEG to page through. It's really too much. So what we can do, we have an automated spike detection in here. And by hopefully mid of the year, we will also have an automatic seizure detection in it, and a video interface, and an event list, and a reporting system which is conformed to the SCORE reporting. I'm not sure whether you're familiar with the concept of SCORE reporting. That's something the Europeans developed, and in Europe it's now the standard of reporting EEG or epilepsy or sleep, whatever, intensive care and so on. And it will be a standard in Europe, and at the moment the Americans think about introducing this standard as well. And I think it will spread all over the world in the future. Then you need around 5 minutes to evaluate the whole thing. So you have 24 hours of recording, and you just take 5 minutes and you have a good overview of what happens to the patient, and the report is ready immediately. Good. What we have, if you have 24 hours, you see you have 4,537 pages of detections or of EEG. Yes, a lot of fun to page through that, especially for the technician who has to do it, and I don't want to be the technician. Especially if you mark an event on the first page and there comes a similar event on the page 512. I bet you will not remember it. Okay, what we can do, we do clustering. What we do, we look on a similarity criteria, we look whether this signal is similar to another signal we detected before. As soon as we collected more than 3 of the signals similar, they form a cluster within a 2-hour epoch. And still, you end up at something like 145 clusters within 24 hours. Still, you cannot review that. You will not remember first cluster and 80th cluster similar. It's impossible. So what we do? We do it again, the clustering. We do the so-called hyperclustering. So we take just epochs with same signals, and they form a hypercluster. So now you can easily evaluate round about 15 hyperclusters. A normal recording, it depends on how much activity has the patient. A normal recording will have between 10 to 20 hyperclusters. That's it. But also in the hyperclusters you will have the eye movement, you will have the sleep things like vertex waves, like posts. Depends. Very easy to see on the map, no problem to figure them out and reject them. Okay, this is something you can really do. And you can decide very fast it's epileptiform or not. And as soon as you do this, a screenshot will be taken, and the report will automatically feed it with that screenshot. And that's the interface for that. So you have here the EEG. You have here the EEG. You definitely have a spike here, temporal basal spike. You see the left aspect. Thank you. What you have here the cluster window. This is all the clusters we collected during these 24 hours, and we have the hypercluster window. And you see you have, in this case, you have hypercluster 1 of 14. And that's definitely epileptiform, temporal lobe epilepsy. And you can here go through the different waveforms. These are the average waveforms of these parts of the hypercluster. This is the histogram. You see this patient is recorded from 10 o'clock to something like 10 o'clock on the next day. And during sleep, he has a lot of epilepsy. So it's pretty easy to see in that case. So what you make is you make decisions up here from epileptiform or not. And if you've done this for the 14 hyperclusters, you're finished and you get your report. And the report looks like this. You have, first of all, the hypercluster information. You have the screenshot to that time point where you took the decision of epileptic form or not. You can certainly do some individual screenshots if you want to see another montage with a lot of other filter setting, want to see if muscle is there, whatever. You can certainly have some different different screenshots, and certainly you can have a comment where you describe left temporal anterior inferior spike negativity and so on. You can easily see afterwards that report. This report is stored as a PDF immediately, and you can get it into the clinic system then, or you can print it out, but almost no clinic is printing out the reports. They just have it in electronic form. And yes, then you're finished, in fact. So, and this takes you around about 5 minutes to do that. And we have really information from the field, and the people say, yes, this program really helps me. After the night, I have 6 patients in my long-term monitoring unit. Next day I come in, I just go through them. Takes me an hour to prepare everything for the meeting with the other doctors, and we go through the patient meeting with the 6 patients. No problem. So that's a pretty good tool for that. Good. Most important for the doctor is a researcher wants to open files. He wants to know exactly what he's doing. The doctor wants not to think in files, he wants to think in patients. So what we have a database here. You select the patient, and you will see immediately what recordings are available for the patient. So that's very nice in this case. Blue means everything has been done, the reporting has been done. Orange means detection was ready, is ready, and you can start reporting if you like. Sand means detection is not ready, so we see here is a detection currently running on that patient, and will be finished in a few minutes. So this represents 24 hours. Then normally the question comes, how fast is this algorithm? We are normally saying that the algorithm is working 8 times faster than real time. So 8 hours takes us 1 hour to analyze. But to be honest, we don't really know, because 8 times faster than real time is really the slowest speed we ever experience. But I've been to Salzburg quite recently, and I analyzed a lot of recordings within some hours, and it were recordings for more than 30 days, and so it was definitely faster than more than 8 times faster than real time. So cannot really say, but 8 times is roundabout there you can rely on. It will be. So it's pretty fast, in fact, and it's okay. And it can also run over the night. All the time, new patients come in, and old data is available. As soon as you prepare, as soon as you have checked the electrodes and said, okay, the electrode set is okay, then this can automatically run over the night and so on, and it will go through the whole EEG folder you define and analyze everything it finds. Good. Key features we have. Yes, we have the automated detection and clustering of interictal spikes into our epochs. Very fast evaluation of the EEG using the hyperclustering technique, a technique we developed, in fact. We allow the physician to decide very quickly on epileptic form versus non-epileptic form, around about 5 minutes, and certainly printed or PDF-based reporting available in there. Advanced display and user interactions. Then we certainly have optimized montages for different recordings. Also here you can take the montage editor. It's also part of that in that software. You can have your own montages. You can define them, no problem. And the database is a really intuitive thing, as you think in patients and not in files in that case. Okay, then thirdly the thing is, well, is that robust? Have you ever proved that? Yes, we did. We, together with the University Hospital of Heidelberg and Oslo and the Epilepsy Center King Cork, which is a gold standard site in Germany, we did an evaluation on children and adults, and what we found out was a 91% spike detection sensitivity in adults and children. And if you look there, between children and adults, the results do not really differ. So we have temporal lobe epilepsy at a 94% detection rate and extratemporal lobe at 90%, and with the adults at 88%. So all in all, you see 94 to 89%, and that's a 91 all in all. So that's a pretty nice result. We were very proud of that. We published that one. You can find it in Epilepsia, volume 53 of the year 2012. Very easy to identify this volume because BESA Epilepsy is also the title page of that volume. We didn't pay for that. I don't know why they took it, but it was very nice. We were very surprised, actually. Okay, so the benefits you have: intermediate overview within 5 minutes. Use traditional EEG spike review. You can do it as well. You can also mark comments in the future, not yet, but in the future this program will have a lot of more features, and this feature will come up in the next, I hope, 3 months, 4 months, and then the program will be extended very, very much. Here it's quantitative number of spike frequency, so you really know how much the people spiked during a certain amount of time. Enhances the reliability of LTM and EEG evaluation, and yeah, that's it. Okay, so that's the other product we have. And then there's another product which is BESA Statistics.